In this final session of reading a normal chest X-ray, we will be looking at the diaphragm, the upper abdomen, and the chest wall. The hemidiaphragms on either side of the midline help separate the thoracic cavity from the abdominal cavity. The right hemidiaphragm tends to be higher than the left hemidiaphragm in over 90% of the patients. It is normally 1.5 to 2.5 centimeters higher than the left hemidiaphragm. In 9% of the normal population, the hemidiaphragms can be at the same level, and in 1%, the left hemidiaphragm can also be higher than the right hemidiaphragm. The interface between the outer margin of the hemidiaphragm with the chest wall is an acute angle called the Costophrenic Angle, and its interface with the heart shadow is called the Cardiophrenic Angle. The Costophrenic angles always tend to be sharp in a normal chest radiograph. However, in athletes, in deep inspiration, they may appear blunt because of their ability to flatten the hemidiaphragm. An erect frontal chest radiograph always includes the upper abdomen, and the most obvious gas shadow that you see is the gastric bubble, which is seen lying under the left hemidiaphragm. Much of the right side of the upper abdomen would be soft tissue density because of the liver that occupies that region. Quite often, a frontal chest radiograph is sufficient to pick up free air under the diaphragm. Beyond the hemidiaphragms and the upper abdomen, we need to look at the chest wall. Superiorly, we have the clavicles, where we need to look at the margins of the clavicles for any contour abnormality, any bony lesions, etc. Follow the anterior and posterior ribs on either side. Look at the bony contours. Also look at the interspaces. Are the interspaces on either side symmetrical? If asymmetrical, a little bit asymmetrical as seen in this patient, look for the curvature of the spine. That might give you a clue on why the spaces are not symmetrical. Now, if they are asymmetrical in a normal spine X-ray, then it is also an indication of possible lung pathology or rib pathology. So if you have a rib injury, you can have paradoxical movement, which can result in alteration of interspace width. Similarly, if there is an alteration in lung volume on one side, you can have an alteration in interspace. A good frontal inspiratory chest radiograph properly positioned would result in the medial margins of scapula on either side occupying very minimal portions of the lung zones. You just need to be conscious about the presence of the scapulae because they can cause overlapping shadows, especially once you start picking up lung pathologies. So two bones overlapping always produces an increased density on the frontal chest projection, and we need to be aware of it so that we do not miscall them as abnormalities on a chest X-ray. After looking at the ribs, the clavicles, and the interspaces, look at the spine. Look at the articular margins of the ribs with the spine, the costochondral junctions, the costovertebral junctions, and you should be able to also identify the spinous process, which is seen as an ovoid structure end on in the midline, and superolateral to either of it, you could easily see in each vertebral body the pedicles also appearing as ovoid structures. Any abnormality involving the pedicles or the spinous process would result in obliteration of these obvious ovoid shape. Presence of any soft tissue mass adjacent to the spine would result in widening or obliteration of the paraspinal lines. So with this, in 4 episodes, we have actually learned how to look at a normal chest radiograph. In the first episode, I discussed the approach to reading a chest. Then we had a look at the normal lungs, the normal mediastinum, the diaphragm, the upper abdomen, and the chest wall. The basic four-step approach by any physician or resident would enable in picking up almost all the abnormalities that can be detected on a frontal chest radiograph. Make sure you identify the patient right, ensure that it is an adequate quality image, look at abnormalities in the lung regions followed by the non-lung regions. A systematic approach like this would definitely enable you to pick up more abnormalities. Thank you for listening.